Good morning, and thank you for attending my Grand Rounds presentation. My name is Taylor Rumbaugh. Today, I will be presenting a case involving a 4-year-old girl who presented with acute right hip pain. This case highlights the challenge of evaluating acute hip pain in children and deciding when benign conditions like transient synovitis can be safely diagnosed versus when a serious disease must be excluded. This case is about a 4-year-old previously healthy female who awoke with right hip pain. There was no history of trauma, no preceding vigorous activity. Family denied rash, insect bites, or upper respiratory symptoms. The child was given ibuprofen around noon. By the time of her visit, she denied pain completely. After completing a more thorough history, Dad did reveal that approximately 11 days ago, she had had a febrile illness, just a very low grade fever that self resolved within 24 hours. And several weeks before that, had had a separate febrile illness. It's important to note that she did have no nighttime pain, no systemic symptoms at the time of the hip pain, and she was walking normally by the time she arrived to her appointment. Her past medical history is significant only for labial adhesions while she was younger and had since resolved. There was no relevant family history, no social risk factors such as travel, tick exposure, or sick contacts. It is important to discuss the tick exposure in our visits because the area that I live in, Lyme disease is very prevalent. So it is something that is often discussed with various symptoms in children that we see. Her review of symptoms was negative for fever, chills, vomiting, joint swelling, or weakness or rash. The only positive finding was the reported right hip pain earlier that morning, which had completely resolved by the time of the evaluation, leaving her with a completely normal physical exam. On exam, she was well appearing, afebrile, her temperature was 98.4. All of her other vitals were totally normal, and she was in no distress. Her physical exam, as I said, were unremarkable. On musculoskeletal examination, there was no swelling, no erythema, warmth, or deformity of the right hip. She demonstrated a full pain-free range of motion, including internal and external rotation. She was in the room ambulating normally. She was able to jump, march, bicycle her legs without any recreation of the pain or discomfort. And the neurovascular status was completely intact of that leg. Overall, the exam did not reveal any red flags that were suggestive of any more serious problems like septic arthritis or osteomyelitis or a fracture. Based on the history of the acute onset of pain with rapid improvement and her benign exam, as well as the absence of any systemic symptoms, the leading diagnosis at this time was transient synovitis. In a child with hip pain, the differential diagnosis can be very broad. There's more benign or common causes like myositis, overuse injuries, or trauma, as well as more serious problems such as septic arthritis, which would be a medical emergency, osteomyelitis, a slipped capital femoral, which is rare at age 4, but cannot be excluded. Also, purse disease, Lyme arthritis, as I mentioned, Lyme is very prevalent in our area, and then malignancy such as leukemia or bone tumors. We would typically expect these to have systemic symptoms or night pain, which was not noted in this case. The Cocker criteria is a set of clinical predictors to estimate the probability of septic arthritis of the hip. There are 4 classic criteria that we look at with this. So a fever greater than 38.5 degrees Celsius, which she did not have. They're typically non-weight bearing. Labs would reveal an ESR greater than 40 and white blood cells greater than 12,000. Also, a CRP greater than 2 can be predictive as well. Our patient was afebrile and full weight bearing. She did not have labs at this time, but with the absence of any other clinical symptoms, she was well appearing. She met the zero Crocker criteria, making septic arthritis extremely unlikely. The literature actually supports that when there is zero criteria present, the septic arthritis risk is less than 0.2%. Although transient synovitis was the leading diagnosis, imaging was still warranted just to evaluate for any kind of occult fracture or bony pathology. While we did not suspect any fractures or malignancies, it was reasonable just to evaluate for the unexplained hip pain. Like I said, to evaluate fractures, any early destructive changes, subluxation or dislocation, early signs of Perth's disease, joint space widening that would suggest an effusion. Also, the x-rays were helpful to serve as a baseline if her symptoms did reoccur. So we ordered a right hip x-ray with pelvis and a right femur x-ray as well for her. We also did give the family orders for labs to be drawn only if her symptoms were persisting or worsening. So these orders included a CBC with diff, a CMP, a sebrate, CRP, CK and isoenzymes, a Lyme test as well with reflux to a Western blot. Um, as I've said multiple times, Lyme is very prevalent in our area. So this approach really helped to balance the need for diagnostics while avoiding unnecessary testing in a child who was well appearing and had resolving symptoms. The management strategy for this patient centers really around supportive care and watchful waiting. We recommended rest, avoidance of strenuous activity. She could continue to use NSAIDs such as ibuprofen as needed for pain, as well as close observation over the next 48 to 72 hours. Transient synovitis typically improves dramatically over 24 to 48 hours and resolves completely within 1 to 2 weeks. As I said, the patient at the time of exam was no longer having any symptoms. We did instruct the family to return for evaluation or call if she developed any concerning signs or symptoms such as worsening pain, refusal to bear weight, fever, or night pain. Really providing this family a lot of reassurance and education was important in this case. Did also provide education that there were several red flags that would warrant more urgent assessment. So a fever, or if she had had a fever, a reoccurrence of her fever, if she became non-weight bearing, was complaining of severe night pain, any joint swelling, erythema, or warmth, any systemic symptoms like lethargy or bruising, persistent or worsening symptoms despite using NSAIDs, any new rash or signs suggestive of Lyme's, and in this case, none of these were present. The prognosis for this case is excellent. Most children recover from transient synovitis, as I said previously, within 1 to 2 weeks, and there's a reoccurrence rate of about 4 to 15%. In about less than 3% of children, so a very small subset, they may later be diagnosed with Perth's disease, which is why persistent or recurrent pain should always prompt reevaluation. Transient synovitis is the most common cause of hip pain in children aged 3 to 8. It often follows a viral illness, as in this case, a low-grade fever 11 days prior. The pathophysiology is believed to involve a mild inflammatory reaction of the synovium, which is likely triggered by a viral antigen or post-infection infectious immune reaction. So, as we mentioned earlier, symptoms typically include acute hip or groin pain, morning stiffness, limping, pain that improves throughout the day, the ability to bear weight, although sometimes reluctantly, and the hallmark feature is rapid improvement with NSAIDs and rest. This case aligns extremely well with transient synovitis based on the age, was in the typical range. She was 4 years old. She had a recent viral illness, sudden onset of unilateral hip pain. She also had rapid improvement after the NSAIDs. She was full weight bearing on exam. There was also an absence of fever or any systemic illness, normal physical exam, and all of these features strongly supported the diagnosis. So, just to summarize a little bit, pediatric hip pain really requires careful evaluation just due to the risk of septic arthritis. The Cocker criteria can be extremely helpful in clinical decision making in this instance. This case had zero of those criteria and a reassuring exam and rapid symptom resolution, which made transient synovitis the most likely diagnosis. Management really focuses on supportive care and monitoring, and imaging and labs should be used judiciously, guided by clinical suspicion and evolution of the symptoms. Here are my references, and thank you for your attention. I'd be happy to take any questions.